That'll help with everybody to be able to hear. Can you hear back there? Is the sound in here all right? It's not hurting your eardrums or... Okay, we have two bills in front of us today, and we're gonna start with the one that most of you are here for, which is House Bill 80. But before we take roll and call this to order, I just wanna, procedures, particularly on these, all issues are important, right? Somebody brings a bill, it's important to them. It's a little piece of their heart they've brought to us in their mind. But certain bills bring more people to these meetings, and this is one of those bills. And so when we have our discussion for and against and debate the merits of it and the non-merits, boy, we're going to do it in a real respectful way and make sure then, and I look at many of you, you've been in this process before, but if it's your first time ever, we're really happy you're here to participate, and then just direct all conversation. And I remind the committee chairs too, because I've made this mistake more times than I can count, but direct the conversation through the chair. It's never back and forth or between us. And then it holds for that civil debate, and then everybody can get their point across. Really appreciate you. And I will always prioritize the people that are in this room as much as possible, but I am sensitive to this new world, this Zoom world we're in now. And we want to, and look at the roads today. There's people that getting here from Cody's kind of hard today, or from Laramie, or Pine Bluffs, frankly. And so even just south of town. So anyway, so really appreciate you here. And with that, can you please call the roll, Ms. Jeffrey?
Yes, good morning. Representative Baer.
Here.
Representative Byron.
Here.
Representative Locke.
Present.
Representative Northrup.
Here.
Representative Oakley.
Here.
Representative Storer. Here. Representative Strock.
Here.
Representative Zwanitzer.
Here.
Chairman Harshman.
Here. Okay, thank you. So members, House Bill 80 is on the table, and this is a committee bill assigned to us by Management Council. And I think, it's a short little bill, but why the Revenue Committee? And I think we want to, we've had a little bit of background trading, but want to talk about the revenue to our state. That's really part of it. So, but part of the deal, when you show up to a meeting, you never know when you might get called on. And normally now we'd have a legislator present this bill, and I could certainly present it from the chair, but I'd like to have the director, Department of Health, and he is totally neutral on this bill. The department doesn't take a stand one way or the other, but if the director, and you're here, so I'm calling on you, and it's not totally out of practice to have the executive branch just talk about this bill real quick. And because the bill is very simple and straightforward. It's just tell us part of the story. Okay, good morning. Please introduce yourself.
Good morning, Mr. Chairman, members of the committee. Stephen Johansson. I'm the director for the Wyoming Department of Health. Part of our oversight is the Division of Healthcare Financing, which includes the Medicaid program, KidCare CHIP, and a few other Medicaid-related programs. Mr. Chairman, as you mentioned, this bill is relatively simple, similar to iterations of Medicaid expansion bills you all have considered over the past several years. Essentially what this bill does, Mr. Chairman, is direct me in the Department of Health to implement the Medicaid expansion as soon as possible, per the language of the bill on page 2. And you see some references there, really referencing the Social Security Act and federal law that has changed since 2010 when the Affordable Care Act was put into place. That's where Medicaid expansion comes from. Just as a reminder to the committee, but also for the benefit of the folks behind me, Medicaid expansion in the Affordable Care Act was originally mandatory. That was part of the law. There was a Supreme Court case a year or so later after the Affordable Care Act passed that, long story short, rendered the Medicaid expansion decision for states to be optional. There's a variety of reasons for that, but it essentially has been optional for all states. To date, 40 states in the District of Columbia have expanded Medicaid either in the traditional way, what we like to call the vanilla way, just expanding up to that federal poverty threshold of 138%, or some states have designed specific components of Medicaid expansion that include other items. And we've briefed this committee, we've briefed the Labor Health Committee, the Appropriations Committee, going back to 2014 on a variety of Medicaid expansion plans that the legislature has directed the department to study or put together or propose. Want to be clear that what this bill would authorize is basically that simple expansion that I mentioned. So currently on Wyoming Medicaid, you do not qualify for Medicaid simply by being low income. We have what are called categorical eligibility criteria in addition to income standards. Things like certain types of disabilities, being elderly and low income or dual eligible for Medicare and Medicaid, children with family income that is very low, and family caretaker adults. That's really aside from our waiver programs, which are specialized to certain populations, our Medicaid program currently has a financial and a categorical eligibility framework. Medicaid expansion as authorized or as an option from the Affordable Care Act is really to expand to adults just up to that 138% of the federal poverty level threshold. So kind of drawing a distinction there, if it's helpful, Mr. Chairman, to the committee, that we are talking about with Medicaid expansion adding an eligibility category to Medicaid that is basically purely based on income, which we don't have in traditional Medicaid. But Mr. Chairman, that's really the nature of the bill in terms of how it would operate. We would, if passed, as we have in other Medicaid-related bills or items in the past, like when we add things to the benefit plan or when we take them away, either through a state plan amendment or through a waiver, what this would direct us to do is to work with the federal government to implement what the legislature passed. I did want to point, Mr. Chairman, if I may, to page 2, lines 11 through 19. There's a few conditions in here that this bill would essentially trigger, that if the Medicaid expansion federal match, and to back up, as I know this committee is aware, because I appreciate the privilege of being able to meet with you all earlier in the week to have a deeper dive into Medicaid expansion as a concept. But as a reminder, the federal government in Medicaid expansion under the Affordable Care Act, to put it simply, pays 90% of the bill. Traditionally in Wyoming Medicaid, our federal match rate is 50%. So it's 50% state funds, 50% federal funds. As we discussed earlier in the week, there's some nuance here because recent legislation from Congress put some incentives in place where, for example, there's a incentive right now from the American Rescue Plan Act that states who expand Medicaid now will receive 2 years of a 5% match increase on their traditional Medicaid program. So we've discussed that. We've put that in our expansion reports. That's a temporary federal match increase on the broader Medicaid program that does generate, significant general fund offsets for Wyoming in the Medicaid program. But in that section that I just mentioned, page 2, lines 11 through 19, you'll see 2 conditions. One, if the Medicaid expansion match, that 90% match that I just mentioned, if that falls below 90%, the expansion in Wyoming per this legislation would terminate. And secondly, you can see on lines 17 through 19, if that incentive were to go away, that 5% match incentive that I just mentioned, that is temporary and authorized through the American Rescue Plan Act, or ARPA, then this authorization to expand would also terminate. Given that incentive, that federal bribe, let's call it, to expand Medicaid, it is currently at 8 quarters or 2 years. The way this bill operates right now is that unless Congress would change and extend that match incentive, then we would be expanding in Wyoming for a 2-year period, Mr. Chairman, as I understand how the committee drafted the bill. Now, can those things change? Can match rates change? Yes, but it would take an act of Congress for that to happen. So I just want the committee to be aware of that. We have not seen the federal government ratchet down the Medicaid expansion match below 90%. That is in law. So again, it would take an act of Congress for that to happen. But with the temporary ARPA incentive, that's really what I did want to focus on. That if we do anticipate that does go away for states, that will essentially terminate and go back to the state's traditional match rate in traditional Medicaid. Hopefully I'm making sense. There's really two things going on with the federal match. There's the traditional federal match for Medicaid, which we currently have at 50%. But again, some ARPA nuance has changed that, and the public health emergency has temporarily changed that. And then there's the Medicaid expansion federal match, which is basically long-term set at 90%. So again, I know it gets irritating and confusing to hear about all these different match rates. Believe me, we deal with a lot of different match rates in the Medicaid program across the enterprise, but happy to get into more detail or answer questions if the committee should have them. And then, Mr. Chairman, I would just reference every year we put out an updated Medicaid expansion cost and enrollment estimates report. We sent that to the legislature on January 10th. And again, appreciate the privilege to speak with you all earlier in the week to answer questions you might have had. Would be happy to share that with anybody who might not have seen it. I believe it is posted on our website as well. And in closing, Mr. Chairman, I would just say, as I told you all earlier in the week, and as you mentioned this morning, these are emotional topics, and I hope it's clear from my perspective, really have made an effort, especially over the past several years, not to put my thumb on the scale. This is a policy decision. And there's good discussion and important discussion on both sides of this issue. What we have tried to do, and especially in the Medicaid expansion topic, is do our best to give you all as decision makers our best estimates, what we think happens, what we think the enrollment would be, the cost would be, who that population is, what some of those dynamics are with the insurance market, et cetera. So with that, Mr. Chairman, joined by Franz Fuchs, our Chief Policy Analyst, we are happy to stand for any questions.
Very good. And I think we'll have several questions. And part of this is for the benefit of all the audience. And I just remind folks, like when I'm up here, I'm taking notes with my pencil. Some are using their computer, but we're all taking notes and working on this. So if you see a computer open, they're not on the Facebook up here, right? They're taking your notes and taking your testimony. So I just want folks to be clear of that. Okay, members, any questions of the director, or assistant director, or Representative Northrup?
Thank you, Mr. Chairman. Director, can you tell me about what the population would be, how many people are going to be affected?
Director.
Mr. Chairman, Representative Northrup, we estimate that in the first 2 years of expansion, or by the first 2 years of it being open, we would enroll 19,000 new members into Medicaid. And we estimate that total cost on a 2-year period would be approximately $22 million state funds and $177 million in federal funds.
2-year numbers.
Those are 2-year numbers, yes.
2-year numbers.
Biennial figures.
Annually, roughly 10 million and 90 million. Roughly.
Mr. Chairman, in rough numbers, yes, that's right. And I would just point out again to the committee, we've tried to do our best to quantify that uncertainty as well, which we talked about earlier in the week. And I am comfortable with the numbers, but I don't want to say that it's, this is set in stone that it will only be 19,000. It might be 15,000. It might be 25,000. But we're really comfortable at our best confidence interval that's what our statistical models show would be the enrollment. And Franz in particular, to my right, has done good work over the past 5 or 6 years to take into account experiences from other states, where you all know there's been undershooting and overshooting of enrollment and cost projections. Our models do account for that for every state that has expanded Medicaid, both on their original projections and what they actually saw in lived experience, as well as various factors that our models incorporate that could be predictors of enrollment, a variety of different things that go into that model. So, but I do want to be clear, these are estimates, but as your health director, I am comfortable with the estimates, and I think we will be very close if the legislature decided to move forward with something like this, I think we'd come in pretty close to those figures.
I'm gonna work right on down. So Representative Bear.
Thank you, Mr. Chairman. I received a call this morning from my community that there was a plane that landed in Gillette last night that had almost 40 Guatemalans on that plane. And based on your comment earlier about the estimates being as accurate as possible, what we know about the border policy in the United States right now, and that information I just received, how would that have been anticipated in your estimates, and has that been taken into account?
Director.
Mr. Chairman, Representative Bear, that's a good question. I might defer to Franz in terms of what the model accounts for with census data and that kind of thing. In terms of, I'm not sure if you're referring to documented or undocumented immigrants. I don't think our model accounts for that in particular with inflows or outflows of that type of migration. Franz can correct me if I'm wrong. But I will say in Medicaid, we have, there's specific provisions for when you have either undocumented or documented aliens that I believe it's only emergency services that are authorized under Medicaid. But Franz, I'm not sure if our model accounts for that. Representative Bear, I wouldn't think so.
Go ahead,
Mr. Chairman,
Mr.
members of the committee, my name is Franz Fuchs. I'm a policy analyst at the Department of Health. Mr. Chairman, Representative Bear, so I think our models do not specifically account for any kind of potential disruption or change in like a low-income population. We will look at census estimates and we try to trend those forward over time for the potential eligibles, so that we specifically look at what are called the small area health insurance estimates. So they try to estimate for states like Wyoming, how many people under 1/30 of the poverty, adults 18 to 64, and that's kind of our denominator. And then we try to estimate take-up based on what other states have experienced. So that's specifically what's in the model. However, as the director mentioned, a plane load of folks from Guatemala would not be legal residents of this state and thus would not qualify for the expansion. They might, if they had a medical emergency, go on to an existing short-term plan in Medicaid called non-citizens medical emergencies. So that's usually a handful of folks, maybe 20 people or so in any given month is in that group. Although with the public health emergency, we've been unable to disenroll people. So that has grown to about, I think, 200 or so now. But baseline, the non-citizens medical emergencies category is around 20 people in a given month. Did that answer your question?
Good question. I appreciate that. It's a good question. And just, you said when the medical health emergency, is that going to end this spring? That's what I'm hearing. And this is all going to change then.
Mr. Chairman, as many of you know, whether it's in front of appropriations or other committees, I've been talking about and planning with you all the end of the federal public health emergency now for a couple of years. It's been frustrating where I've said it could be next quarter, But we have, with the recent legislation out of Congress, the Consolidated Appropriations Act, there were a number of things that happened there related to my agency and Medicaid, one of which is the triggering of the unwinding of the public health emergency. So that will happen, Mr. Chairman, we will start making notifications this month of renewals in Medicaid that need to, application renewals that need to happen, and we anticipate beginning disenrollment for non-eligible members in April.
A couple of quick questions, just for clarification. So the current baseline of numbers is, sorry, thank you, Mr. Chairman. The current baseline of numbers is what, and then the 19's on top of what number, just to make sure I understand the numbers. So roughly how many do we have currently?
Mr. Chairman, and I'll give you Representative Locke, two figures. In any given month, we typically have between 50 and 60,000 people on the Medicaid program across all of our different programs in Medicaid. Annual numbers look a little bit higher because as folks churn on and off during the year. So enrollment's better to look at on a monthly basis to get a better sense. And pre-pandemic, that's typically around 50 to 60,000. So that 19,000 of new enrollment would be on top of that.
Okay. Representative Zwanitzer?
Thanks, Mr. Chairman. So obviously, by not having Medicaid expansion right now, we are shifting people on all other programs, 50/50 matches. I guess fundamentally, and maybe it's just my opinion, that we're paying for it already. We're just moving people into workers' comp, Social Security, any number of other programs to meet the needs of this population. Have there been any kind of internal studies on the, I hate to call it cost savings, but on moving them back onto a program like Medicaid expansion for this 1 to 137%, where that would save us funds across the board in other federal state match programs?
Director?
Mr. Chairman, Representative Zwanitzer, that's a very good question. Let me address a couple of items there because it is a big topic. There are a variety of programs, as you mentioned, that folks who would be in the Medicaid expansion population can do or would qualify for in Wyoming. A comprehensive analysis of that is difficult, but I'll give you a few examples of what those offsets might be if suddenly those services were covered at 90% federal match. We see that potential in a few public health programs. So think of things like our cancer screening programs that provide those largely with general funds or grant funds. There is a provision or an offset that we could see by looking at folks in Department of Corrections, so in correctional institutions who receive care or hospital stays outside of the prison or the jail that could be matched in Medicaid. There's a non-insignificant population in corrections that would qualify for this, but to be clear, you don't qualify for Medicaid if you're in a penal institution. So this would only be if you're, have to be discharged and have a, potential expensive stay in a hospital in Rollins or in Casper or what have you. So that's a potential offset there. We have in the past looked at mental health and substance abuse costs where we do have significant funds that go to providers around the state to care for folks' mental health substance use needs. And if the Medicaid population grew in this sense and that match rate increased, we could grow the pie there, so to speak, and offset general funds. So there's a variety of areas, Representative Zwanitzer, that could be achieved, but it's not all unicorns and rainbows, because I want to be clear that that takes political will, both internally and with this body. That when you talk about offsets, even if it's net positive, that's can be felt as a cut somewhere else to a specific program. While from the population perspective who's receiving the service, it might be a net to zero, but those are, programs that have been set up over the years, and we have studied those, but just want to be clear that it doesn't happen automatically, if that makes sense.
Okay, I'm going to I think Representative Oakley, and then I'll work with anybody.
Thank you, Mr. Chair and Director. I guess I'm feeling a little unclear from a practical standpoint, from administering the program. What do you think would be the effect if passed in its current form? So on page 2, line 17, 18, you mentioned it. If it was less than 55%. I mean, what are we setting ourselves up for there if it passes this way? I guess if you could clarify for me.
Mr. Chairman, Representative Oakley, to put it simply, the way I read this, because that 55% that's mentioned on line 19 there, that is a temporary incentive from the feds for 2 years. So the way I see it operatively is that if passed, this would be a 2-year expansion for authorizing us to have the Medicaid expansion. Practically, that would mean the legislature would then be reconsidering, if it expanded in this way, the temporary match incentive went away after 2 years from the federal perspective, then the legislature would need to either reconsider, amending that authorizing statute, or we would terminate the program, if that makes sense.
Go ahead, follow up.
Thank you, Mr. Chair. Yes, that's exactly what I was thinking I understood, but I thought certainly, I guess maybe you've said you don't want to come from a policy standpoint, but that seems like that would possibly be a huge mess. So implement the program for 2 years. I mean, would that, do you think if it went as such, and the 67th passed it, let's say, and it is not extended, that would be a massive, difficult, like, undertaking to start the program and then to not have it?
Mr. Chairman, Representative Oakley, yes and no. Again, if it were, if the program was authorized and it operated for 2 years, we would just, and it were powered down, were taken away because that match rate went back to 50% in traditional Medicaid. There's a notification, there's legal processes we have to follow to notify members in certain timeframes. So would it be administratively intensive for potentially, 19,000, 20,000 folks? Yes. Could we do it? Yes. But it would be, there'd be a lot of mailings going out. I'll put it that way.
Okay, and that federal change in the FMAP, that 5% is how much again? How much money?
Mr. Chairman, with the 8 quarters or 2 years of the FMAP incentive, we estimate that, calculate that on our traditional program at about $54 million per biennium of offsets to general funds. So $54 million in
54 million.
savings to
So
the
it's
general
really
fund.
enough to pay the state share for about 4 years. Really? The 54 million,
Mr. Chairman, potentially, yes.
even though it's a 2-year. And I think that's part of what we're trying to solve in this bill is this FMAP overall on our whole Medicaid program. As you know, 50/50 is the lowest it can be. Idaho, I think, is 70% federal, 30 state. I think Montana's in the 60s. Utah's in the 60s. South Dakota's high 50s. Nebraska's high 50s. Colorado's like us because they have one county like us that changes our state average household income dramatically. I mean, without Teton County, and I love Teton County, but we're not a 50/50 state. Is that right? Without Teton County? Not to delve into this too far, but just to kind of
Mr.
so
Chairman.
folks understand what we're trying to fix with this.
Mr. Chairman, for the record, Teton County is warm in my heart, but you're right. We have studied this over the years. Teton County does have an influence on Wyoming's per capita income calculation, which generates our federal match. And we estimate that if Teton County were exempted, that we'd be around 57% match, as opposed to the floor of 50/50.
Which is, yeah.
But I would also mention, Mr. Chairman, as we've discussed, that is in this Social Security Act. So it's not something that unfortunately I can negotiate with CMS. It's a congressional action there.
Okay, I think Representative Storr had a question.
Thank you. A couple questions on the population that this will serve. Thank you, Mr. Chairman. Director Johansson, when we talk about Medicaid expansion, we often are thinking about that population that is above the federal poverty level, but can't afford to buy health insurance on the marketplace. But just based on the presentation and our discussion earlier this week, I just wanted to clarify, because we focused a lot on also the people who are below the poverty level, and that this would serve them who currently don't have an affordable insurance access. Am I correct in understanding that?
Director?
Mr. Chairman, Representative Storr, yes, and if you'll allow me, I think it's helpful, at least in my mind, to stack these populations. So when we talk about Medicaid expansion being from adults from 0 to 138% of the poverty level, there's a lot going on in there, especially with how the Affordable Care Act works. So we currently, as I mentioned in Medicaid, we don't just have low-income programs. It's low-income plus categories. A category that we have, which is a family care adult, is from 0 to about 56% of the poverty level. So extremely low income who caretake for children or, an adult child maybe with a disability.
Not to interrupt, but what kind of dollars are you talking about? I mean, 56% for one person.
Mr. Chairman, 56% of the poverty level for one person about $6,000-7,000 a year in income.
Okay, thank you.
But Representative Storer, to your question, we have a couple of populations to talk about in Medicaid expansion. And as you mentioned rightly, it's helpful to say the population under the poverty level, who is that? And the population slightly over the poverty level, so 100 to 138%, who is that and what access is there? Below the poverty level, so 0 to 100%, that's really what we typically refer to as our coverage gap, because they currently don't qualify for Medicaid, but currently don't qualify for the subsidies that we've all known about and discussed over the years that are on the Affordable Care Act or the Obamacare marketplace. There's significant subsidies for folks above 100% of the poverty level to purchase a very inexpensive health insurance on the marketplace. That population below 100% is really where, I think as your health director, where my concern lies, that the insurance products are just completely unaffordable and Medicaid eligibility is not there. We estimate that group, out of the total 19,000, is about 60% of our projected enrollment. It would be under the 100% of the poverty level. Mr. Chairman, correct. Those subsidies, again, artifact of the Affordable Care Act. They do not trigger for anybody below the poverty level. Again, it goes back to, I think, the original intent of the ACA and the expansion was that it would be mandatory. And so those populations would have been covered by Medicaid on a mandatory basis. And the Supreme Court rendering that optional kind of created this nuance and this gap. In closing to your question, Representative Storer, if I may, Mr. Chairman, we talked about this earlier in the week. It has been a policy frustration for many states that expansion, taking that population from 0 to 138% would remove people from those exchange plans through private insurers. I mean, heavily subsidized by the federal government, but they would now be transitioned onto the Medicaid program. We addressed that in our studies and in our analysis. It's referred to as crowd out, Medicaid crowding out those private insurance plans. So I did want to mention that because it is a real effect that would happen. Now, again, as we discussed, it's heavily federally funded Medicaid versus heavily federally funded private insurance subsidies. So on the financing side, it's not as distinctive, but certainly on the operational side, I've been, the governor and I have discussed this. We've had numerous legislative conversations about it, had discussions with CMS about what we call partial expansions. States have proposed, could we expand just up to that 100% of the poverty level with the same, 90% match, the same kind of strings, but not remove folks from those ACA marketplace private insurance plans who fall between 100 and 138%. To date, the federal government has not approved one of those partial expansions, but especially in the previous administration, there was discussion about that and some soft approvals in concept for partial expansions. Utah comes to mind as an example that really moved that forward. As you all know, Utah then expanded fully through a ballot measure, I believe. So it kind of rendered that effort moot. But as I've discussed, we will continue to have those conversations, especially if an effort like this, if it does or does not move forward. I think it's a reasonable policy discussion with the federal government to tailor that expansion if possible. But certainly no promises there. I can't speak for the federal government.
That might be a
We have not seen approvals.
Helpful amendment. I just have three things, and then we're going to let you go because we got a lot of folks, and I know you'll stay here, but there's a couple things out there. I want to first talk about the abortion issue. You talked to us about Medicaid and abortion and the Hyde Amendment and federal law, and what's the history of Medicaid paying for abortions in Wyoming?
Mr. Chairman, in the interest of time, I can answer that very briefly. Wyoming Medicaid does not cover abortion services, and we don't plan to.
Okay, my next question is, there's some information I'm receiving that there's been a change in the law that these people 0 to 100 can qualify for the silver plan or one of these subsidized plans. Is that true? Was the law changed?
Mr. Chairman, not to my knowledge. I might ask Mr. Fuchs to address that, but no, I
think it was in an earlier version of the law that got stripped out, is my understanding.
Mr. Chairman, that's right. But currently, as the law is today, to qualify for what we call advanced premium tax credits and cost sharing reduction subsidies, for sake of conversation, let's call them subsidies from the federal government for those ACA marketplace plans, your income must be over the poverty level.
So there's nothing 0 to 100.
Mr. Chairman, that's correct.
Okay, and then my last question is, I hear things and I get feedback from people around the state, well, the administration, it's just it's a bureaucracy that is inefficient and most of the money goes to administration and not actually healthcare. So can you kind of give us some background on private insurance, admin costs, and who pays, is it CMS? Maybe explain that to people who CMS is. That I didn't know what it was when I was getting emails from CMS years ago. So.
Mr. Chairman, CMS, or the Center for Medicare and Medicaid Services, is the federal agency that oversees and regulates Medicaid programs. In terms of admin costs, helpful way to think about it for Wyoming Medicaid, about 95 cents of every dollar in the program goes for reimbursements for care. So it goes for the medical care.
Goes to the doctors.
Correct.
Providers.
And we typically, it depends on the program, but we typically run a 2 to 5% admin cost in Wyoming Medicaid. And we've baked all of that into our estimates here, noting for the committee that while the services in Medicaid expansion are reimbursed 90-10, 90% federal, 10% state, admin costs per the law are still 50-50. So we've accommodated for that. But Wyoming Medicaid, something I'm proud of the team at Wyoming Medicaid. We do operate, relatively speaking, in a low administrative framework. But we are also what we'd be considered a big plan for Wyoming. 50, 60,000 members, that's a lot of covered lives. So we do operate at scale, where smaller plans, smaller insurance products just have more admin. They advertise, they have various reporting and actuarial requirements. So certainly no slight against,
Sure,
private insurance,
no.
but we typically do see higher admin cost in private insurance because of those factors.
Okay, I think and I know we could spend our whole time with you two gentlemen, but we've got, and I just trying to clear up some of those things I'm getting through emails to make sure that, is there anything else like that? I think that's most of it. So thank you all, appreciate you. Okay, so here's what we got. We got 8:43 right now. Do you have a question, the director? Okay, quickly, go ahead.
Thank you, Mr. Chairman. My one question was, so the emails I'm receiving, the reason people really would like this is that the federal government, then their money is going in taxes into federal government. And so they want to see that money come back. But what I'm understanding is it's only based on the enrollment. And if you add extra to it, then Wyoming is 100% liable for it. It comes out totally from us. It's only what the estimate cost is a federal.
Can you answer that? If
Mr. Chair-
estimate is 19,000 people.
Mr. Chairman, Representative Strzok, it's a good question. Let me see if I understand and correct me if I didn't. If we exceed, the question is, if we exceed enrollment, then the state is liable for those costs. And that's not true. We estimate the enrollment that we think will happen, but let's say instead of 19,000, let's say it's 25,000 people came on the rolls of expansion. That same breakdown in the cost of 90% federal, 10% state would still apply. But you're absolutely right that 10% of the cost for an additional 6,000 people would be additional cost to the state, but it would still be at that 10% match. And so you can see some of those scenarios, an uncertainty in our report that we shared with you all, and we're happy to follow up offline if there's additional questions.
Thank you, good question. Okay, so thank you, gentlemen. And then, so it's 8:44. So here's the plan. Let's do, we're gonna do I'm gonna break this up, half hour each. We're gonna go half hour for those folks who are opposed to the bill, have problems with the bill, and you've got a half hour. So one person could talk for 30 minutes, or 30 people could talk for 1 minute. It's gonna be your choice. And then at 9:15, we're gonna pivot, and for those folks who are in favor of the bill, and you'll get a half hour. And again, one person could take all 30 minutes. And then that'll put us at 9:45, 15 minutes before we gavel in, and then we're gonna work the bill and vote on the bill. Okay? So any of those folks opposed to the bill, folks who and actually you can just come on up and fill the seats. That's the quicker way, and we don't have to wait for one person at a time. So when one seat comes open, somebody could just fill it up. And introduce yourself, who you represent, and where you're from. And we're glad you're here today. So go ahead, you're first, go ahead.
There we go, I'm on, okay.
Yeah, and then that green button will.
So I'm John Mansell, Dr. Mansell, speaking for myself and for the Wyoming Society of Anesthesiologists and for providers from Campbell County. Possibly about to be the most unpopular person in the room this morning. I appreciated the director saying that this is a policy discussion, and I want to make sure that everyone in this distinguished committee understands that as a physician, doctors and nurses want to take care of patients. So the basis of all my comments today is not based in political ideology. It's just in a description of the policy and where we believe the policy will not help Wyoming. I saw patients yesterday. I drove down here. I'm going to leave this hearing and go back and see patients tonight, and I'll see patients again tomorrow and even on Saturday. So I am truly in the trenches in healthcare right now. I'm not an administrator or have any other jobs. I'm not a lawyer or lobbyist. I'm certainly not a legislator. So a lot of people in the room here today are going to talk about the need for Medicaid expansion, and we recognize that need. The problem is they're not going to be able to tell you how it's going to work. And the reason is that the fundamental characteristic, if anything, the defining characteristic of Medicaid is it does not pay enough to cover the cost of the care. And for that reason, since 1993, about 7 years after Congress passed an omnibus bill that reduced our rates of reimbursement, we've seen the cost of healthcare for everyone else has gone up because of cost shifting, where Medicare and Medicaid didn't cover the cost of the care and made it expensive for everyone else. And so for us who work every day in healthcare, it sort of baffles us why we're going to double down on adding more people that don't cover the cost of the care, because the people who are still trying to pay for their own insurance and healthcare are going to suffer as a result. So by adding in more people in what we would call, if we were hospital administrators, negative margin market share, doesn't really make sense to us. Right now, on a national average, Medicaid pays about 86 cents on the cost dollar. Notice that's not the retail price of the care. That's actually the cost of the clinic, hospital, or provider providing the care. And so as a result, every time Medicaid at the national level or the state level spends $10 million, you're hollowing out $1.4 million from the balance sheet of your healthcare infrastructure in your state. So in a sense, even if it costs the state of Wyoming nothing, by expanding a program that takes money out of the system, you're cannibalizing your own healthcare infrastructure in the state of Wyoming. And that means that we can't build to cover caring for more people. So if we added 19,000 people into the system here, and quite honestly, we as providers think it's going to be closer to 57,000 people, because we're seeing people moving from the coastal states because inflation's driving them out of there. And so I see 1 or 2 people a day who comes from either the Northeast Corridor, New Jersey, Pennsylvania, or from Washington, Oregon, or California that say, I can't afford to live there anymore. So they move to Wyoming. And we don't think the models support that or recognize that, in addition to our southern border problem. And so in a sense, our concern is that people who want to expand Medicaid are conflating coverage with care. Because what ultimately happens is that while I see Medicaid patients and we recognize the existing Medicaid program is a critical program that we all support to take care of those people who've been dealt a bad hand in life, when you expand Medicaid, some providers either start rationing and they can only see so many a day or so many a week or month, or they just stop seeing Medicaid patients completely. From the administrative end, from the state's perspective, to try to preserve the program when it gets out of budget control for you, the states have tended to lower their reimbursement rates. So for example, some of the physicians who live in Wyoming actually lived in a state where they had expanded Medicaid and they couldn't afford to live there anymore. As an example, an anesthesiologist in California or New Jersey gets paid if they're doing an open heart anesthetic or a Siamese twin separation or a liver transplant. After they pay their malpractice and the cost of billing, they earn $23.50 an hour. Needless to say, that's before they buy their own healthcare insurance. So in a country where 44% more physicians are more likely to commit suicide than the average person, and 50% of physicians say they're burnt out, I don't know how we would be able to help support an expansion where we could neither fiscally afford to scale up to it or work harder to try to scale up to it. Anyone who tells you that all doctors in this state are for Medicaid expansion is not being honest with this august committee, because we're not. And in Campbell County, I would say we're almost unanimously against expansion because we have seen where Medicaid has either not worked or we've seen where the existing program has been abused. For example, Campbell County's got a great unemployment rate, but when you have a 2% unemployment rate, but 43% of your babies are born on Medicaid, somewhere someone's getting something over on us. That's a pretty big disconnect. One of the reasons that we see so many homeless people in cities with mental health problems is because Medicaid doesn't pay enough to cover the cost of the care for those people. That's why they're on the street right now. So it's a terrible failure in that particular venue. And in our own state, one of the reasons we have to look at considering assessments for our psychiatric hospitals is the same reason. Those same patients are on a program that doesn't cover the cost of operating the hospital. So why would we want to convert all of our hospitals into the same fiscal crisis? One of the things we like about Wyoming is that we're exceptional. We really are an exceptional state. We're beautiful. We've got a great work ethic. We're small enough that we can reach out and talk to our leadership, which is just awesome. And one of the other things that's made us exceptional is we haven't fallen for this carrot yet where we would expand our own Medicaid by taking federal money and hollow out our own system. There are so many other good ways to actually lower the cost of healthcare and make healthcare accessible, which we won't go into today, but if anyone's ever interested, I can give you a white sheet on that. It's quite brief. And if you think that giving people COVID money made them less likely to go to work, wait till you give them free healthcare, because you can create your own eligibility to be on Medicaid expansion. It's not hard to do. You just don't have to make money. You don't have to work. And so what we tend to see also in the models is they don't account for that. They don't account for the people moving to our state because we have a lower cost of living. And we're concerned that we're going to get overwhelmed with this. I'm a doctor. This is policy. This is not politics. I'm truly worried that if you start Medicaid expansion, this is going to be a runaway train, and every other department's budget is going to be a stalled car on the train tracks, and they're going to get destroyed by this because it'll grow out of your own control. And because it's a federal program, you won't have control. You would do much better to have a direct aid hospital program where you just paid the hospitals their losses for uncompensated care, which we think will be less than the losses from undercompensated care when you expand Medicaid. Thank you, Mr. Chairman, for letting me speak today.
Thank you, Doctor. Appreciate you being here and driving down here and your testimony. Appreciate your service to the people of the state. So any questions for the good doctor? Representative Bear.
Thank you, Mr. Chairman. I would just like you to briefly describe your experience. I understand you accept Medicaid patients of human behavior. This is free healthcare to these recipients of Medicare, Medicaid, I mean, and obviously they need it based on their income and their conditions in life. But what is your experience when you have people schedule appointments on Medicaid as far as they're showing up and they're taking advantage of the system?
Mr. Chairman, Representative Bear, I would say 90% of our no-show patients are on the Medicaid program. And that's from practicing from 32 years. I'm getting old. If they have no skin in the game, there have been economic studies that show that people just don't treat it as valuable. And so we also see we're a small percentage, and I can't give you the exact number, but it's less than 20%. I think it's 10 actually use up to 80% of the cost of Medicaid because they're overutilizers. And we have people on this program, the core program, not the expansion program in Campbell County, who come to the emergency room 20 to 25 times a month. And if McDonald's was forced to sell to 1/3 of their clients hamburgers for a nickel, the lines at McDonald's get pretty long. And when we give away free healthcare with a copay of $2.45, we tend to see the overutilization. Again, doctors and nurses want to take care of patients, but there is a point in time where we either can't afford it because in a small office like mine, it costs about $175 an hour to run the office. That's rent and staff and malpractice and all the costs that go along with any business. but Medicaid only pays us $160 an hour. So not only do we not make any money for the provider there, we actually lose money just covering the costs. There's one provider who traditionally has been a Medicaid expansion supporter. And so out of respect, in Campbell County, so out of respect, I called them on the way down from Gillette yesterday and said, okay, I'm going down to testify, and you and I have traditionally disagreed about this. So to be respectful and to make sure I don't paint Campbell County with too broad a brush, what would you have me say or do tomorrow? And they said, well, she said, I can't support expansion because just supporting the core program right now, I can only pay myself $30,000 a year. And when they give a vaccination that costs them $240, Medicaid has reimbursed them $2. For me, it's X-ray contrast. I get 90 cents for a $99 bottle of contrast. And so one of the other secrets of Medicaid is they don't actually cover a lot of the incidentals. And so that forces us to have to do the rationing, you know. And that's the sad part of the program that I think is a policy 5 years from now, it's not going to improve the health of the average Wyoming citizen, which of course is what everyone wants to make sure we preserve, physicians and legislators.
Okay, thank you. Any questions? And I'm just at 8:57. I'm just trying to, everybody, so you're down to 18 minutes. Okay, go ahead.
I'm okay then, Mr. Chairman. I have appreciated Dr. Mansalona. It's probably been 9 years now that we've been having this discussion.
Yeah.
Maybe I should check. You are still a director of the Wyoming Liberty Group, though. Is that correct? I don't think you mentioned.
I used, Mr. Chairman, I used to write white papers for them on this topic years ago, but I've never served in an official capacity for them. I do serve on several other boards, both national and local. But again, speaking for myself today.
Yeah, okay, thank you. Representative Storr?
Thank you, Mr. Chairman. Just one quick question, sir. It seems like that there would be greater coverage for uncompensated care with Medicaid expansion. So please help us understand why you're opposed to this, even though it seems like you would go from 0 for uncompensated care to something that the state and federal would pay for. Thank you.
Mr. Chairman, so this is a great statistical trick that gets pulled on us all the time, because people will ask me, well, what are you going to do? And the problem is you don't want to do the wrong thing, you know. Better to do nothing than to go in the wrong direction. So if we have uncompensated care, and this is from the Hospital Association's own numbers, costing them $120 million a year, but you have 57,000 new people who are undercompensated, it's actually going to cost the system more and encourage more people to go into a program that undercompensates. So it hollows out the infrastructure. A better way to attack this would be to allow the marketplace to normalize. And again, I don't want to get in the weeds on this because we have limited time, but here's a little known or discussed fact about pricing in healthcare. If you own a gas station, you got to post your price, right? A big sign up front. If you're in healthcare now, we have transparency laws, but the transparency laws are meaningless because if you are covered under a healthcare insurance contract right now, within your deductible, you have to pay the network price. So that means there's no price signaling. I will tell you that senior leadership at Blue Cross Blue Shield is ecstatic about the concept of banning price fixing within the deductible, because then you make me compete on pricing. And then people who don't have healthcare coverage right now would be able to come into me and haggle and say, I'll give you $100 for that. And I can do that without endangering my contract for Blue Cross. And Blue Cross likes that because it means all of the covered lives become empowered hagglers to get a better value for their dollar. And when we're able to do that, everyone else gets to come in on that haggling as well. So now I can advertise $199 for something that used to be price fixed at $899. Then it becomes affordable for those 19,000 people. But it's normalizing the marketplace, not trying to put a Band-Aid on a dysfunctional marketplace. And there are several other measures that cost the state of Wyoming nothing we could do to that end. Thank you, Mr. Chairman.
Thank you. Okay, we better keep moving. Representative?
Thank you, Mr. Chairman. So I'm Representative Sarah Penn. In my other life, I am a nurse practitioner. I've been a nurse practitioner for about 15 years. And unlike my friend Dr. Mansell here, I am a legislator, and I took time off from my job to come and advocate for people, because this is one of the main issues that people are struggling with. They're not feeling like their voices are being heard. When we're talking about Medicaid expansion, people are saying, well, you know, we have a problem, and I'm not disagreeing with that. We have a problem that we need to fix, and there are other options besides Medicaid expansion, as has been alluded to just now. People are saying, well, we've got to do something. Policy needs to be made upon reason and not emotion. And when we're in an emotional state trying to make a difficult decision, we're setting ourselves up for difficulty. So let's discuss a little bit further. We've discussed a little bit, and I'll try to be brief with respect to time. We're talking about a lot about percentages, and it's difficult for people to grasp. So let me just talk some numbers here. I have in my hand a charge sheet from one of our Wyoming clinics. A charge for a chest x-ray is $153. Medicare reimburses $25. Not so good. Medicaid reimburses $17.82. And that includes the fee for the radiologist to read that image. $153 is a very fair and reasonable price, considering the equipment and the manpower and the training that goes into take that. And to say that reimbursement at $17.82 is acceptable, I would disagree with that. And it's crippling our system. What happens, as was also alluded, is we have to limit the number of patients that we can see. We have to raise prices on other things, and a lot of times both of those situations is what ends up occurring. Outside of the pitiful reimbursement, Medicaid as an entity is very difficult to work with. There's a lot of back and forth. A lot of things, charges that go out that maybe they've paid for in the past, and they say, no, I'm not going to cover that. And there's a lot of haggling back and forth. I have in my hand here a study from July of 2021 that was performed by the Bureau of Economic Analysis, the University of Chicago, and the Federal Reserve Bank of San Francisco. And what they looked at is what additional administrative burden is placed on healthcare because of those back and forth, those haggling to try to get the reimbursement that they are owed. What they found is the estimation that physicians lose an additional 17% of their Medicaid revenue to billing problems, compared with 5% for Medicare and just 3% for commercial payers. This is a very long study. I can provide it to you. It's 70 pages worth of information there, but their conclusion and all that they were looking at is what ends up happening here is the response to those billing difficulties and the pitiful reimbursement is physicians simply just stop accepting Medicaid. And so we're trying here to increase access to medical care, and this does not allow for that. It doesn't increase access. We've talked a lot about the 90-10 match and how that's a great thing for us, and it can, you know, bring a windfall of $32 million. And, you know, there's a lot of numbers that get thrown out or discussed here. But what about that 90%? You know, we're worried about what's happening to the state costs, but the people are also worried about what's happening in our country. And we can't be blind to those things. 90% of this cost is to be borne by the federal government. In no entity other than government would we consider to go into a partnership with a business that is $32 billion in debt and continuing to print money. It's not good business. Also, outside of that, I would like to remind us all that the federal government doesn't have any money. They get their money from the people. It's still tax dollars, whether it's state tax dollars or whether it's federal tax dollars, it's still coming out of the pockets of the people. We say a lot about strings. Federal dollars come with federal strings, and being on the Labor and Health Committee for just 2 weeks, there's a very prominent trend emerging, and that is we come up to these issues that an issue we need to address or a problem we need to solve, and we want to go this way, we want to go that way with it, but we're met with a block. We can't do that because Medicaid won't pay for it. We can't do that because if we do, then we're going to lose our funding. Medicaid is going to pull out. A government solution to a government-created problem is not the answer. I'll try to cut so that others can get their time in. if basically what we're alluding to is, we have a table set with a meal and we have so much food on that table and it's enough to feed a family of 5 and they leave that table well fed and full. But if we have the same meal on the same table when we invite 5 or 6 families to sit down and share, all of those people end up leaving hungry. I have great respect for the people in healthcare, my colleagues and my friends and people who I've been on the front lines with for years. I have great respect for the things that they're trying to do, and they're doing it because they love it. But they're not actually miracle workers. You can't ask them to feed the 5,000 with just a few loaves of bread and a few fish. We don't want healthcare in our business. Government in our business as providers because they dictate how we can treat patients. I may say that if a patient comes to me with this issue, and I think we need to do this and this and this to try to help them and figure out what's going on with them, I'm often very limited that I can't do these things. I can do a couple of these things. So we're gonna go with that. We try it and then we get the kickback. Well, maybe Medicaid at one point paid for that and now they're not gonna pay for it. Well, we've already done it. The cost has been assumed. And so who ends up covering that cost that they kick back and say, I'm not covering it? The facilities end up covering those costs. Medicaid is a stage 4 terminal cancer, and we cannot be enticed to allow this into our state. We have to be, it's a difficult decision, but as legislators, we need to make difficult decisions. And I would urge some very thoughtful consideration on both sides and address this with logic and with reason. Thank you.
We got about 4 minutes now. I'm not going to use this clock. It says 9:11. This one says 9:07. So you got 8 minutes. Okay, thank you. And I think if you're done testifying, maybe open your seats up for others can fill in. Go ahead.
Okay. Mr. Chairman, members of the committee, my name's Ross Schriftman. I'm a resident of Casper. I moved to Wyoming in 2021 from Pennsylvania, as a good doctor said, for the lower cost. In 1975, I became an insurance agent. I served as the legislative chair of the Pennsylvania Association of Health Underwriters, Health Insurance Agents, National Long-Term Care Chair for the national organization. I have several designations. My testimony, thank you, is being distributed. I'll try to keep my comments brief. That's why I provided a written testimony. I have several designations. One is registered health underwriter. One is advanced chartered benefit consultant. I've been working on healthcare reform, health insurance reform since 1989. I am a volunteer. I am not compensated by any organizations or reimbursed for my travel down here from Casper this morning. The department did explain in my testimony about the background of the U.S. Supreme Court decision concerning the Medicaid expansion, so I won't go over that. Federal overreach is one of the concerns I've had over the years. The 10th Amendment limits the role of the federal government and allows the states and the citizens to make most of the power decisions over their lives. In addition, after World War II, Congress passed a bill called McCarran-Ferguson. That bill settled some of the disputes between federal regulation and state regulation. Over the years, the federal government has blown through those guardrails and has created many, many programs, including the Medicaid program. As has been mentioned, Medicaid has a waiver program, but talking about the population between 0 and 100%, you go to them and say, "Mother, may I please?" And they say, "Well, let's put it in a committee." I will be talking to our new member of Congress probably Saturday. I'm going to bring up some of the things that were discussed today to see what we can do about that population. But Medicaid expansion is not the direction to go. The doctor mentioned the reimbursement. In 2018, I had a CT CAT scan. Independence Blue Cross would have paid $900. Medicaid was $400, and Medicaid was $200. So that's a concern. And again, whether it's 50% or 90%, the federal government doesn't provide the money, the taxpayers do. In 2015, when Tom Wolf became governor of Pennsylvania, he expanded Medicaid. I was still selling health insurance at the time. I don't anymore. It became too complicated to sell individual and group health insurance. In fact, Independence Blue Cross paid zero commission to agents, and they were the only ones in the Philadelphia area. But at that time, I was getting calls because I was being referred by my clients to other people. They were losing their private insurance. They were being forced into Medicaid, not by the governor, because the subsidies stopped. The insurance companies sent these people cancellation letters. I could not help them. They were losing their doctors because, as the anesthesiologist just mentioned, the reimbursements were too low and they weren't, their doctors weren't available. Medicaid was designed as a temporary measure. If you remember, I'm old enough to remember President Clinton, who stated welfare to work. It was always a temporary measure. What our goal should be is to encourage people and get them out of poverty, find work for them. There's many opportunities in the state. Maybe we will even start a auto manufacturing gas in Wyoming. There is also, today is a very special day in Congress. Again, they've come to the debt ceiling. How many times have they done that? It's been mentioned 32 trillion, but I would suggest you look at the Social Security and Medicare trustees report. We're at $90 trillion of unfunded liability, and those programs are paid for by workers. So we need to get more people working. Our employment labor force is only at 62%. That means 38% are not working. If the problem is the able-bodied people within that limit, let's find them employment. Let's get them trained. There are programs, and I know in Casper, I'm very proud of that community I moved to, because there's programs for mentally ill people, for job training within those organizations, and we can do a lot more. Let me just conclude if I have a moment. Solutions for Wyoming. First of all, I want to make sure that we are regularly auditing our actual eligibility. Some of the states like California have exploded. Idaho has exploded in the number of people that are actually ineligible. Are there performance audits of the program, how outcomes are coming for those people that are insured? How many people that are already eligible within these programs that we have aren't enrolled? Who's enrolling them? And the other thing is, we have insurance agents that are active in the state that can help insure people and find them employment. So I'll take any questions if my time hasn't run out.
We are right about any questions, Mr. Schiff. Appreciate you
Yeah,
driving
yeah,
down
and my
here. Appreciate
information
you.
is here.
I have a quick question, Representative Bear.
So thank you for being here, Mr. Ross. Ross, I'm sorry. The courts have often said that once a government provides a public benefit, that if it's taken away, it requires due process. This particular benefit of Medicaid expansion, in your opinion, do you believe that it will become something that cannot be taken away, as this particular bill suggests, without due process?
Mr. Schiffman.
Yeah,
Go ahead.
Mr. Chairman, Representative Bear, one of the things mentioned in my testimony is the fact that the year before the ACA became active, Medicaid enrollment was 54 million. It is now at 90 million. So it never seems that, I mean, it's really hard to take people off their coverage unless they're forced, as happened in the Commonwealth of Pennsylvania. I have, in my entire life, I have not seen any programs. And other than the one they're talking about now with the pandemic. But I would suspect, and I would bet, that that doesn't happen because they're not going to send letters to people saying you lost your Medicaid. But they did send letters to people that lost their private plans when ACA. I was one of them. I'm an insurance agent. My premium went from $200 to $700 a month, and I couldn't put money in my health savings account. But that's a private plan. But the insurance companies, the cost of insurance has not gone down. It's gone up. It's just that it's masked with the subsidies.
Okay, thank you, Mr. Shipman.
Thank you.
Appreciate you traveling here today.
Sure,
and
it
your
was a little
testimony.
hairy this morning.
Yeah, I really, and be careful out there. Appreciate it.
Wyomingites are tough, you
Yeah,
know.
we are, that's for sure. It's, well, really appreciate you being here. Okay, we're gonna shift now to those. I got 9:16. I'm gonna start my timer. You might fill the seats, please. 30 minutes, those in favor of the bill. And we'll start now, 30 minutes. So go ahead, and I think, like I say, 30 folks in 1 minute or one person 30 minutes. Go ahead.
Thank you, Mr. Chairman, members of the committee. My name is Mike Lehman. I represent the Catholic Diocese of Cheyenne, which represents the Catholics around the state of Wyoming. And I thought I would just talk a little bit about kind of the philosophical approach. I was recently asked if healthcare is a proper role for government to be involved in. And I think that's a good question and worthy of debate. In my mind, when I think of any group that might come together and agree to form a government, one of the first things they want to ensure is that they will be protected. That's why they form military and law enforcement. So the protection of human life is preeminent. That's why so many of us are adamant about the legal protection of the unborn, which I will talk about a little bit more in just a minute. Now, how does ensuring access to healthcare to all compare to that first role of protecting life? Whatever our opinion is with regard to that, I think many Wyomingites agree that it's more in line with protecting life than many, if not most, of the other roles that the state is involved in. When this question is considered, we also need to ask if getting government out of healthcare is actually a principle that we intend to follow to its logical conclusion. Do we really intend to call into question access to healthcare for all Medicaid and Medicare patients and all veterans? Is this a principle we intend to stand firmly on, or is it a question merely being raised in order to avoid the question before us this morning? I represent a nonpartisan organization. Approaching legislation from a nonpartisan standpoint is not easy, but it forces one to consider what many think of as a preposterous notion that maybe both sides have some things right, and maybe both sides have some blind spots. One thing I wish my friends who lean left would understand is how inconsistent it feels when the state is asked to help one vulnerable segment of the population while simultaneously saying that the intentional destruction of another segment of the population is none of the state's business. Currently, our Wyoming statutes hold many places where the state claims authority to take action according to what is deemed, quote, in the best interest of a child, unquote. At the same time, the state still turns a blind eye to the violence of abortion, which intentionally takes the life of children. This has created a lack of integrity on the part of the state. As I've said many times before, if being human and alive are not enough to constitute full legal protection from the state, what else is necessary? Who gets to decide and on what grounds? History is full of actors who insisted on adding qualifiers, like the color of one's skin or one's sex. Those actors never added qualifiers that they themselves did not already enjoy. I believe we'll be far more successful convincing our neighbors of our responsibility to take care of all people the moment we stop excusing the destruction of some of the people. One thing I wish my friends who lean right would consider on this particular question is that some slopes are more slippery than others. Not every government program is an inevitable slippery slope into the fiery pit of socialism. We need to recognize when our colleagues are manipulating our fear that is the case. The legislature puts side rails on laws all the time that prevent such slides. I imagine the committee could do the same with this particular question. It's important to distinguish between access to health care and what is unfairly constituted as all welfare programs. I was born and raised in Wyoming. Wyoming people don't sit around and dream up more ways to go sit and spend their free time in the doctor's office. If anything, we avoid doctors. So we need to consider that. And finally, Mr. Chairman, I just want to say that the floor speeches that were given 2 years ago on this question were very compelling to me. When we heard some of our most staunch pro-life leadership, testify that they had voted against this every time for 7 years then. And they did that because they believed that there was another program, there was another option, there was some other thing that could be explored. And at the end of the day, they kept coming back to their constituents with the question of how long? How long do we say no before we provide an actual option? And many of them said, we've looked under every rock, we've looked under every stone, and at a certain point, we need to answer that question for them. I found that very compelling. When these questions keep coming up over and over again, like Medicaid expansion, the question of that, like abortion, I think we all need to come to it with open hearts and critical minds, and ask ourselves, is it possible that I might have a blind spot here? Is it possible that I might have been missing something? With that, Mr. Chairman, members of the committee, thank you for your consideration and for your service to the people of Wyoming, and I stand for any questions.
Representative Bear.
Thank you, Mr. Chairman. Mr. Lehman, we've talked about the Hyde Amendment. I'm sure you're familiar with it. We no longer have that in the federal statutes as far as keeping funds from being used for abortion. The states of Indiana, Utah, Wisconsin, Iowa, Mississippi, Virginia, and possibly others have used Medicaid dollars for abortion. We have federal mandates coming down. We've seen that much used during the COVID pandemic. Do you trust the federal government not to mandate that Wyoming start using these dollars for abortion?
Deacon.
Mr. Chairman, thank you, Representative Bear. So just quickly, the Hyde Amendment has been struck.
Mr. Chairman.
I'm sorry.
I was not aware of that. I know there was an attempt to, but I didn't think it was successful. But go ahead, Representative Bear. So Department
Just
of
to
Health
clarify,
knows that.
the Hyde Amendment in the most recent budget is not included. So it no longer protects entities from using federal dollars for abortion.
And maybe we can get some clarification from the department on that, and we can certainly write that in this bill. We have in the past. Okay.
Thank you, Mr. Chairman. Representative, I was not aware of that. That is an ongoing threat that we are working against in every state around the nation to ensure. And that's going to be the case. We will always be working to ensure that. It's an ongoing battle because, once again, it's an issue that keeps coming up for a reason. So.
Okay, very good. Thank you. I think we have an elected official online. I'm going to go to him. Appreciate you. And then you can empty that chair and we'll come back to another person can fill it. I think, is Representative Buttry still online? He's gone. Okay, then we'll move on to who's next. Who wants to go next? Go ahead, introduce yourself.
Good morning, Mr. Chairman. My name is Jasper James Chen, JJ for those who know me a little bit better. I have a couple of hats I'm wearing this morning, so I'll declare all of them. The most obvious one is Healthy Wyoming. I am also the immediate past president of the Wyoming Medical Society. I am also an inpatient psychiatrist and chief of medical staff at Cheyenne Regional Medical Center. I am also a first-generation Wyomingite, having moved here, married to a fourth-generation Wyomingite, a God-fearing one, because she's from Rock Springs. And so I'm happy to be here just to give a simple message this morning. As a psychiatrist, I see daily when I take care of folks the options and opportunities that are afforded to them. One of the things I have noticed is the big difference any type of insurance may play in how I may use tools and psychopharmacologic medications and even therapeutic interventions that are available for those who do have insurance. It does obviously depend on the kind of insurance, what we're able to do, but having any kind of insurance I think is very, very vital and important. I would also like to clarify that the individuals, my clients and my patients that I discharge, are discharged because they simply no longer meet criteria to stay in the acute inpatient hospital setting. We cannot legally detain and hold on to individuals that do not meet clearly Wyoming State Statute Title 25. So I'm very, very aware of that. And that's the reason why I must discharge folks within a certain amount of time, given their expected length of stay for the condition and the mental illnesses that I'm purportedly treating during the time that they're with me. I'm happy to stand for any questions or concerns.
Any questions, the good doctor? Okay, Representative Bear.
Thank you, Mr. Chairman. Thank you for being here, Mr. Chen. As a psychiatrist, I've gotten in a little bit of trouble for challenging the idea of affirmation when it comes to transgender sex change treatment from your industry. I'm curious if you believe that Medicaid expansion could allow for the funding of either psychiatric care that would lead to affirmation or potential medication and surgery for that particular area.
Mr. Chairman, thank you, Mr. Chairman. Representative Bear, this is a Pandora's box question. I probably do not have sufficient time to go into all the details. I personally believe that as a psychiatrist, my duty first and foremost is to take care of the patient. I do see a lot of times where folks who do have the diagnosis by our statistical criteria, our diagnostic and statistical Mann criteria, DSM criteria for gender dysphoria, they are at greatest risk of having completion of suicide, having attempts of suicide. We see that a lot. I take care of a bunch of individuals who are transgendered, either male to female or female to male. That is something that I believe we'll continue to see. So I know that is an area that we will having to spend much more time kind of considering the ramifications of that. Already living in a state where we do have one of the highest per capita suicide rates in the nation, that is unlikely to change, unfortunately. But we do have means of kind of suicide prevention efforts. We have our 988 program as well. We're trying to do our best to make use of very, very limited providers in our state, including psychiatrists, psychologists, to be able to take care of folks who have gender dysphoria. And I'm sure there will be more to come on that.
Okay, very good. Doctor, what about we heard from another doctor and and appreciate you being here, just about the reimbursement piece.
Yes, I agree. Thank you, Mr. Chairman, that Medicaid reimbursement rates are not ideal. It's not optimal, and yet there's no perfect system to expand mental health infrastructure. There are many, many things that I would like to see in addition to more adequate and optimal reimbursement rates. One is that we have to consider alternative ways of taking care of people, try to prevent unnecessary hospitalizations. I, for one, could see, more group home considerations, more, institution of appropriate guardianship here when it's appropriate to take care of people. We have long waiting lists here, obviously, for all sorts of mental health infrastructure services. And that is unlikely to change with either the expansion of Medicaid or not. However, I have to be realistic and think what is the best alternative to what we currently have, and that possibly would be to expand Medicaid right now in its current form. I believe that as a federal taxpayer, I believe that more of that money could come back home to take care of the patients that I'm taking care of. That would be a very, very wonderful thing in my humble opinion.
We'll move to Mr. Sweeney.
Good morning. Thank you, Mr. Chairman. Pat Sweeney from Casper. So I provided, I guess they're coming now. In the element of time, one of the handouts is an article that from the Casper Star that appeared this past Sunday. I won't go into that. I will go into this chart once you get that handed out. So my story, I'm a former legislator. My first session was in 2017, representing House District 58, totally against Medicaid expansion. I campaigned on that. Fast forward, because of I had several businesses in and around Casper and other parts of the state. At one point, between 250 and 300 employees in total. and we couldn't afford it as a business. So I got into the legislature after selling a lot of those businesses, and we'll fast forward to 2019. 2019, my first four sessions, I was on labor health, then was corporations for two years, and moved to revenue committee for the last 4 years. And it became evident in 2019 that we needed to do this way before the pandemic and move forward with Medicaid expansion. Why? The recent study, which I only printed the executive summary from the current model, but what I saw in 2019 on that study, this study is not much different. And I thought that the state Department of Health did a great job in analyzing. At that point, I think it was 37 states, it might have been 36 expansions. But in summary, it really made sense to me to move forward for our citizens. And I felt at that point it was about 10 million. Then comes along the movement with the current administration on this additional 5% match for our FMAP. So I'll draw your attention to the bill on page 2, and this has already been discussed on the 90-10 critical, but that 5%. My belief is that, number one, because of Teton County, and we love Teton County, don't take that wrong, but because of that factor, and I've marked on here the current rates of our surrounding states. How does that affect us? And so what that FMAP actually is, when you average that all out, is 60.79%. So moving the 55% and giving the department and the governor the options to negotiate. That's what this bill really does. You can look at it different ways, but I believe if we simply are allowed to negotiate through this process, and with that, I will end. I've got other things, but there's a lot of people here to testify.
Got about 13 minutes left in this. Any questions, Mr. Sweeney, former Representative Sweeney? Appreciate you driving down
Thank
here
you.
and testifying. Okay, next, go ahead.
Mr. Chairman, if I could interrupt, we do have Ed Buttry online now.
Okay, I think we'll take, he's an elected official from Montana that we've gotten to know. I'd like to have him spend a few minutes with the committee. Is that okay? And then you're next. Okay. Can you pull him in?
I'm admitting Representative Buttry.
Hello, Mr. Chair.
Welcome.
Thank you, Mr. Chair, members of the committee. I'm Ed Buttry. I represent House District 21 in the state of Montana, and I'm speaking to you today as the guy that carried the Medicaid expansion bill in Montana in 2015. We call it the HELP Act, which is the Health and Economic Livelihood Partnership Act. And I appreciate the chairman giving me a few moments to talk about what we did in Montana and some of the data that we've collected on our plan. We've had, as I said, we've had the plan in place since 2015. So now we have a lot of different folks collecting data on what the costs are, what the benefits, what the advantages are of the program. Data is king. So I'll try to stick to the facts as much as possible. When we set out to implement a solution, we had a couple of goals, which I'll briefly discuss. First of all, and obviously and most important, was to improve the health of Montanans, both physically and mentally, and including providing more access to substance use treatment, which we really needed to do. Just like most or all states, we're sending a significant amount of money to the ACA, to DC, and we wanted to bring those healthcare dollars back to Montana and put them to work here within our borders. And we certainly had the same concerns as Wyoming in saving our rural safety net hospitals and businesses. We also wanted to utilize our program to provide a pathway out of poverty for our low-income population, because of course we recognize that a healthy workforce is a productive workforce. So as part of our expansion plan, we created an economic development program called HelpLink, which is specific to this population and requires the state of Montana to assess each member and to identify barriers to employment or to better employment. And so in the bill, we set aside some funding for training, mentoring, and also utilized a partnership with the private sector to identify employment opportunities for members based upon their skills and abilities and what help we could give them with training. And in the end, we actually created the largest, most focused, and most successful economic development plan in the state's history. But members of the committee, as I talked about earlier, we've been measuring data since inception of the program. I'll first talk about some of the non-financial impacts that our program has had in Montana since 2015. We found that our expansion population, over 70%, about 72% of those members are already working, but we did further increase that workforce participation in Montana about 6 to 9% for this membership. We saw substantial gains in substance abuse treatment opportunities for the population. The population saw a reduction in crime greater than 3%. We showed an economic upturn. This is prior to COVID. We believe that if we provided some basic training and skills, that when business and employment opportunities arose, that this population would fill those jobs, and they did. Prior to COVID, when we were in the economic upturn here in Montana, we saw our expansion population reduced by over 10%. And that was when we had more jobs with benefits available, and those folks went into those jobs. We also saw uncompensated care reduced over 50%. It was over a $200 million savings to our hospitals, and also especially to our rural critical access hospitals. Our emergency department use reduced by this population over 13%. And this population, when we surveyed their health, the excellent health category has grown by over 5% every year. Our members have stayed on the plan on average about 2.1 years. And our employers in Montana have saved over $1.1 billion. That was just in 2019 that would have been spent on providing health insurance for these enrollees. So that's the non-financial impacts. If we look at the financial model, and I tend to always look at both sides of the P&L. We have a lot of people talk about just the expenses, but I'm also going to look at the state savings and new revenues. The expenses for Montana, the cost of the state is about $80 to $85 million a year. And that's at the 90% FMAP that we get from the feds with our program. So it's costing us $80 to $85 million a year. If we look at savings, there are a significant number of people that had been covered by traditional Medicaid that we were able to move over to the expansion group and get the higher federal match. Things like the breast and cervical treatment program, medically needy programs. There's a number of those that came over. There are different studies that estimate how much savings that's given to the state. This one ranges somewhat widely, but all studies agree that it's somewhere in the range of $20 to $55 million per year. So right there, we're covering between 30 and 65% of the state's cost for the program. If we look at savings outside of Medicaid, we have over $2 million per year savings in substance abuse and mental health programs that were formerly covered by state spending and now are paid for through Medicaid. Our inmate hospitalization costs reduced by over $10 million per year. I think it's about 10.5 now. So that's a savings of over $12 million annually, or 17% of the state's cost of the program. We use something called the hospital utilization fee. That brings revenue into the state and the hospitals. We have an inpatient fee and an outpatient fee for our hospitals that are paid to the system. They're matched with federal money, but the state also retains some of that money into the Medicaid expansion plan. That generates about $15 million per year. And that goes towards offsetting the state's cost of Medicaid. And then we have our additional revenue to the state. We've created over 6,000 new jobs. Currently, we are seeing over $400 million in new personal income that's taxable, $700 million new dollars in new economic activity. And what the state is getting out of this new tax revenue is about $43 to $46 million per year. So if we're looking at any of the studies, the Manat study, the University of Montana study, the others that have been done, it is obviously seen that the costs of Medicaid expansion are more than covered by the savings and revenues that come to the state. We actually are estimating at somewhere between 120 and 160% of the state's costs are recovered annually. So if anyone is going to tell you that Medicaid expansion is financially unaffordable in Montana, they're just flat out wrong. Of course, we see the other benefits. This is good for the physical, mental, and financial health of participants. And we have not had a single rural critical access hospital close since we've incorporated expansion. They are financially healthy. We're taking care of them. And just as a point of interest, if you look at Medicaid spending as a share of state general fund spending, the data I have shows that in Wyoming, your Medicaid spending is 17% of your state general fund spending, and in Montana, it's 12%. So, Mr. Chairman, I rushed through that. I know you're under some time constraints. I am as well. My committee I chair is currently in session, so happy to answer any questions, but would ask be excused as soon as possible.
Yeah, well, thank you, Representative, and I think we appreciate your background because we hear a lot of things. We hear how it really ruined Montana, and I spoke to your former speaker and president up there who I got to know, and he didn't support it, but he said it probably, his comment to me was it probably saved our rural critical access healthcare in Montana. But
yeah, it did, Mr. Chairman, and in fact, if our program were to go away now, the impact to our general fund would be substantial.
Okay, and then if we just ask the committee to ask if you can maybe send us some of your information that you covered today, that'd be helpful. Thank you,
So,
Representative.
Mr. Chair, I'll send a copy of my testimony as well as the different reports that have been generated on our expansion program.
Very good. Thank you and best wishes. Thank you for joining us. Okay, moving back. Go ahead, please.
Committee, thank you for granting me the time to speak with you today. I was asked to share a little of my story. My name is Madeline Prince. I'm a nurse and a first-year medical student in the WWAMI program. My husband is a missile maintainer at F.E. Warren, so we live here and I make the drive over the hill to Laramie most days. But I'm proud of my family's story. We are living proof of the American dream. I grew up in a trailer house, and there were times when my parents should have taken me to the hospital, but didn't because my family was uninsured and unable to pay the ER costs. In fact, I have a scar from when my sister dropped a treadmill on me when I was 7. We were trying to move it to make space for a game and thought we could do it on our own, and of course we couldn't. So I ended up with a big gash on my thigh, but instead of taking me to the ER, my dad, who was in nursing school at the time, just bandaged me up as best as he could. Fortunately, all I have is an ugly scar, and we miraculously avoided any major medical catastrophes or expenses the rest of my childhood. Now my father, Dr. Colin Prince, is a pediatric nurse practitioner and one of the few child and adolescent mental health specialists in the state. I finished my nursing degree 3 years ago and worked as a pediatric nurse across the street at CRMC before starting medical school. Any large medical costs could have completely derailed my family's trajectory, and I'm really grateful that we were fortunate enough to avoid them. I hope that when I return to work as a physician in Wyoming, I just will be able to care for all Wyomingites, not only those who can afford insurance. So I'll keep it brief, but that's my story, and thank you so much for listening.
Well, appreciate you. Any questions for the good? I'm going to call you doctor. You're going to be there before you know it. Are you first year or second year?
Just the first year.
Oh, good for
So,
you. So
yeah,
you're studying, working hard.
working hard.
Yeah.
Yes, thank you. Thank you all. for
Any
your
questions? Okay, well, we appreciate you and best of luck on your program and your rotations and all that. You got a lot ahead of you.
service. I need the luck. Thank you.
Thank you. Okay, we'll just go in order. You go and then the good doctor will finish. Go ahead.
Thank you, Mr. Chairman, members of the committee. I'm Josh Hannes with the Wyoming Hospital Association. I'll be very brief, just a couple of points. One thing for a little bit of historical perspective, starting in the early 90s, again in the early 2000s and up until today, former governors, this legislative body has commissioned different task force groups to look at how do we address healthcare in Wyoming, to lower cost, increase access, and so on. All of those reports, though in the early 90s, they certainly didn't call it Medicaid expansion, had some recommendation that talked about how do we fund a way for low-income people to have some sort of health coverage. Do we do it on a state level? Do we leverage the Medicaid program? Certainly today, Medicaid expansion is the option on the table and most of those costs covered by the federal government. If we were to do something like that on our own now, as you heard the Department of Health talk about, you would have something in the realm of about $1 billion a year, or $100 million a year additional cost the state would have to bear to cover that gap that currently exists in our state. Certainly, I think that Medicaid expansion is a better way to finance that coverage and to get people access to care. We talk a lot about, there's other ways, there's state ways, and we always talk about that in the abstract. But when you put stakeholders in a room, they come up with relatively similar ideas over the course of the last 30 years. So I just wanted to provide that context for the committee. I'd also like to just direct you all again, excuse me, to your Department of Health's analysis. Net provider revenue in their estimates is positive. Yes, Medicaid does not cover the full cost of care. Yes, they consider the crowd out from the commercial plans. The net effect is positive to providers. Montana hospitals saw about a 48% reduction in their uncompensated care. Rural Colorado hospitals are financially strong as a direct result of Medicaid expansion. And then the last thing, which I think is probably most important, when you provide coverage to people, they can access care in the right place at the right time. The evidence from other expansion states demonstrates, particularly for people with chronic conditions, they can see a primary care provider, they can pay for medications, they can maintain their health, they can go to work. Absent that, they show up in an emergency room, which is expensive and an inappropriate place for care. So I'll be brief so other people can speak, but I would encourage this committee to move forward.
And tell us again who you represent.
Excuse me, Mr. Chairman, the Wyoming Hospital Association.
Okay, thank you very much. Okay, we're down to the last bit here. Doctor, 30 seconds.
Very quickly, Mr. Chairman, Dr. Hollis Hackman, I'm a psychologist from Sheridan representing the Wyoming Psychological Association. We've supported Medicaid expansion from the time it rolled out a decade ago. Representative Buttry hits many of the points I wanted to make, and primarily they have to do with how access to care was increased for mental health sorts of and behavioral health sorts of issues in Montana. It was increased in a dramatic way, and for that reason, we are in support of Medicaid expansion. Stand for any questions.
Any questions? Okay, appreciate your work. Okay, your last 30 seconds.
Mr. Chair, committee members, thank you. I'm a small business owner, maybe a very small business owner, and it's been pointed out that Medicaid expansion is not perfect. I agree. If you could strike that 2-year provision, I'd be all for that. But I support Medicaid expansion. It would give me more options. Right now, I can't afford to provide health benefits to our employees, and this would be one more option that might get me there. Thank you.
Okay, thank you for being here. Question? We have a question for you.
Oh, Mr. Chairman, I don't think Mr. Dalton said his name for the record.
Oh, I'm sorry. That's my mistake. Go ahead. Just introduce yourself.
Sorry about that. Eric Dalton. I own Bellafoco Pizza. It's 2 blocks over that way if anyone's hungry.
Okay. Very good. Thank you. Okay, with that, we're gonna close public testimony as we're up against the clock here on this, and appreciate everybody being here and as we've gone through this. Okay, I just want one clarification from the department on the Hyde Amendment. Representative Bear mentioned that the Hyde Amendment has been repealed. I just want to find out if that is the case. I'd heard that there was an attempt by the Biden administration, but that the Senate had blocked it.
Mr. Chairman, my understanding, and you know how difficult it is to track things in Congress, my understanding is that there was a spending bill from the House a year ago or so that stripped the Hyde Amendment, but that it was reinserted into the budget. I believe where we stand today is that the Hyde Amendment is in effect. But certainly we'll work to confirm that, Representative. And I did want to clarify one thing I mentioned with Medicaid, Wyoming Medicaid not covering abortion services. That is true. There have been instances when life of the mother is at stake and it's medically necessary. Over the past 20 years or so, Wyoming Medicaid has paid for maybe 2 or 3 abortion services. So I wanted to be clear for the record.
And that was the life of the mother? you
It
said?
was, and it's an emergency, a life of the mother provision, but wanted to be clear so that I didn't misstate that. We certainly don't cover it on an elected basis.
Representative Oakley has a quick question.
Thank you, Mr. Chair. Thank you, Director. So along with that, can't there be state-specific rules made, so not only in regards to abortion, but we also heard about transgender, if that's something that Wyoming specifically wanted to preclude, isn't that available?
Mr. Chairman, Representative Oakley, yes, but I will also mention there's kind of a squishy area with Medicaid and Medicare where we talk about medical necessity. So if things are medically necessary, and again, that can get a little bit squishy, but it takes it out of the department's hands and puts it in the provider's, physician's hands, then it does turn into a gray area. But yes, in general, those sideboards on many of our programs and coverages and budgets can be done at the state level.
Okay, very good. Okay, members, do you have a question, Director?
Thank you, Mr. Chairman. So based on the states that I mentioned that are using Medicaid dollars for abortions, it's pretty clear that the Hyde Amendment, if it's in the Senate version or not, it's not being enforced, at least in those states. Would you agree?
Go ahead.
Mr. Chairman, Representative Bear, I wouldn't disagree. I just don't know that those states are doing that. I'd have to either talk to my counterparts or look into that.
Thank you. And follow
What
up.
were those states? And maybe you can check if you wouldn't mind. Follow up. Could you, those states?
I can
you
provide
mentioned?
those, yes.
What states were they?
Give me a moment.
I couldn't remember. but-
Those states were Indiana, Utah, Wisconsin, Iowa, Mississippi, and Virginia for sure. There may be others.
Okay, so Director can check with his
And
counterparts.
may I have a
Go
follow-up?
ahead, yeah.
Thank you, Mr. Chairman. Based on what Representative Oakley said about creating exemptions, is it true that once the state is in an agreement with CMS, that CMS can change anything within the agreement at that point?
Go ahead, Director.
Mr. Chairman, Representative Bear, related to Medicaid expansion or Medicaid in general. So it's a joint program, so we do have to live within federal law and rules. But there are items which the states control, for example, spending and budget, certain optional coverages, that type of thing. In terms of Medicaid expansion, to answer a question in another way, it is optional. So the state, I have confirmed with HHS numerous times over the years that the state can withdraw, and this bill contemplates that. If match drops at a certain level, the state expansion would go away. So that is also permissible. But I hope that answers your question, Representative Bear. It is kind of a nuance between what we have to cover and what we can optionally cover.
Okay, very good. Thank you. I'd like to get working this bill if we can. And it's hard because he knows a lot and we'd like to pick his brain for a long time, but I think he's available for any. Okay, members, bill's ready. Is there a motion on the bill?
I'd like to move House Bill 80.
It's been moved. Is there a second? It's been moved by Representative Swanitzer, seconded by Representative Oakley. Okay, we'll just flip over to the page 2 of the bill, really. Are there any amendments to the bill? Members, yeah, Representative Bear?
I would like to propose an amendment on page 2, and I may be.
We can do a concept and
Okay,
work it with
great.
staff.
Thank
You
you.
bet. Go ahead.
Thank you, sir. I would like to propose an amendment that no federal, state, or other funds will be used for puberty blocking, neutering, or chemical drugs, or surgery for the treatment of gender dysphoria.
Okay. Motion, is there a second? Second by Representative Locke. Any further discussion? I think you all understand the motion.
Just a question, Mr. Chairman. So that you mean Medicaid expansion dollars of what would come in under the Medicaid expansion for those people from 100 to 137%?
I think that's what we're dealing with.
Yeah,
That's the bill.
within this program.
Yeah.
Yes, sir.
Okay, very good. Okay, any further discussion? Okay, all those in favor of the motion say aye.
Aye.
Oppose? No. I
No.
think that motion's been adopted. Division being called. All those in favor, raise your hand. 1, 2, 3, 4. All those opposed? 1, 2, 3, 4. That motion has passed. Okay, any other motions?
I do propose a couple more, if I may, sir.
Go ahead.
I propose an amendment that says that no federal, state, or other funds will be used to market this program to the population of Wyoming.
Is there a second? Seconded by Representative Strzok. Further discussion? All those in favor of the motion, please say aye.
Aye.
Opposed? No. Okay, that motion has failed. Okay, any further amendments?
One more, sir.
Yeah, go ahead.
I propose an amendment that we include $3 million of federal dollars to be reserved for marketing of the cancellation of this program to those affected by its cancellation.
Okay.
And I just came up with that number based on, I propose that we reserve $3 million of federal funds for the marketing of the cancellation of this program to those affected by its cancellation. I mean, I just picked a number based on statewide marketing.
I'll second.
Okay, I think we understand. Any discussion? All those in favor of the motion say aye.
Aye.
Opposed?
No.
Chairs in doubt. Those in favor, raise your hand. I love this committee, man. They're all close. 2, 3, 4, 5. That motion has passed. Okay. Okay. Any further motions? I guess I would like to make a motion in this bill to make it really clear that the provisions of the Hyde Amendment apply to this bill.
Second.
Okay, and those are those limitations on the use of these funds for abortion. Make it crystal clear, even if the federal government removes the Hyde Amendment, our provisions, and we can just reference state law. That's long-standing state law, and we'll find that provision that's already in state law. Good lawyer here knows that. So it's been moved and seconded. Discussion. Representative Bear.
I would just second the idea that it be based on state law versus
Yeah,
the Hyde
and-
Amendment, which may be in question.
That's right. And we have in state statute, folks, we have the Hyde Amendment has been in there for years, right? And so that I would reference that, and we'll find that statute reference. I don't have it on the top of my head, but we'll find it. So that's the amendment. Any further discussion? Okay, all those in favor, please say aye.
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 Opposed? Okay, that's been adopted. Any further amendments?
Question?
Okay, question being called on the bill.
Can we discuss?
Oh, you want further discussion? Sure, go ahead. We'll take a minute. We'll take a minute. We might miss roll call, but we'll be all right. We'll be all right.
Thank you, Mr. Chair. I just wanted to say that for a little bit of discussion, I mean, of course, this is an important topic. It's an emotional one. But on balance, I mean, I'm an I vote. I think I think it's actually almost shocking, $10 to $11 million annually, as far as, not to say that that's an irrelevant amount of money, but when we look at our budgets and the money we have, that's, I mean, it's almost a pittance. From Wyoming and from the community, I've received hundreds and hundreds of emails, hundreds. People are certainly interested, and the vast majority are in support of this. I do believe that, I think we're there. I think it is the will of the people that Medicaid expansion pass. And as we just discussed with some of these amendments, I'm willing to look at sideboards. I'm willing to find a compromise. If we can have that discussion, I'm fine with that, including, as I just voted for the transgender, affirmation, then we can do that. But again, I think it's the will of the people, and I think we're there. I think it's the right thing to do. So I'm an aye vote.
I have received much of a different perspective from my constituents and those around the state that I've spoken to about this program. And frankly, I do not trust that the federal government, which changes dramatically from one administration to another, will not mandate to the state how they can operate this program. Much as we saw throughout the pandemic, the federal government has mandated many things that the people of this state are not in favor of. And I fear, as we discussed the issue of abortion, that though we put it into our statute that we won't be a part of the program if these things are mandated from the federal government, I fear that the federal government will force us. And I have seen within the legislature of the state of Wyoming that once we become dependent on federal dollars for these programs, we are not very motivated to move away from these programs and put these federal dollars at risk, even if it's distasteful what the federal government may force us to do. And so for that reason, I'm opposed to this bill. This is incrementally taking us down a path that we've already gone a long ways down. And at some point, we must say, we're not going to be held captive by the federal government. We're not going to be told how we're going to do business in Wyoming. We have values that are very different from those of New York and those of California. And if we don't say no now, I'm afraid that there will be no difference in our society from those of New York and California. I'm a no.
Any other discussion, members?
Mr. Chairman.
Representative Storr?
Thank you, Mr. Chairman. I just in commentary to Representative Bear's comments, I would just argue that there are a lot of things that the state of Wyoming is dependent upon the federal government for. Certainly 95% of our roads in the state, our water development. This is one thing that really can make a difference in people's lives. And I would agree with Representative Oakley that the time has come and the people have spoken. Thank you.
Okay, any other discussion? Representative Locke?
I would have to kind of follow up with kind of the discussion on the fact that I'm sorry. Thank you, Mr. Chairman. I'm sorry. I just want to kind of follow up on that issue of the fact that once those federal dollars go in place, I mean, look at what's happened with COVID. The same kind of situation as most of you know, especially a business owner. I know there was a small business owner here earlier, and he discussed the fact that he was for this, but I'm sure he would probably also mention the fact that he has a difficulty hiring people. So people have, once they got a taste for those federal dollars, they stay on those. And plus, as it was mentioned earlier today, that states, once they get on a federal program, very difficult to get off, and has been found to be a very significant legal battle to get off. I just wanted to bring that up, so I'm definitely a no vote on this.
Any other discussion? Representative Strong?
Thank you, Mr. Chairman. We learned yesterday that how in debt we are as a country, and if we don't change our ways, we are not going to have a country. If you just look around the world at the countries that don't change their spending ways. And then, so I am a no vote on this. If we don't change our spending ways and everyone thinks it's free money, I don't know, printing money is going to destroy us, and there is nothing as free money. Thank you.
Okay, any other comments?
Chairman?
Okay, go ahead, Representative
Yeah,
Butler.
I certainly stand in favor of this, and I think we need to, think long and hard about making these decisions based on fact and not fear. Thank you.
Okay,
Question.
okay, and I'll just wrap this up. My little experience, I voted against this probably 10 times. I was appropriations chair. I cast a deciding vote in the committee, killed it. In a year, it probably would have passed. And partly because some of the fear, I mean, fear and faith both believe in a future, right? That hasn't happened yet. But I think as I've learned more, because we wanted to go down the road of every other option, cowboy care, I had an amendment to open up the state plan of insurance, couldn't do any of these things. We tried all this stuff. And so I kept voting no on it, and kept working on options. There's been no other option. And in the meantime, then I think, and I know I appreciate the church referred to me as the most pro-life speaker in the history of Wyoming. Part of this is I've served, I've learned a lot. I've just learned so much. And as I learned more, it's the right thing to do for people. And I think the people of Wyoming who have been opposed to it have come around. I think you've seen that kind of even nationally. It's just coming, and now we're down to 10 states that have not passed this program. But there are people, most of us don't even know, have very tough deals. Now, then there's people, who is this really going to affect? It's going to affect mainly women ages 25 to 35, and 2/3 of those women are working today. And then the other group it's going to affect are seniors, about 58 to 65, before they get on Medicare and get administered by CMS again. And so those are the groups that are in this gap. And we're talking about folks who make less than $12,000 a year. And most of them working right now. We just haven't come up with a better idea. And so that's why it's in revenue. And anyway, I think it's going to be really good for our small town hospitals too, who are a couple $100 million a year in uncompensated care, because these people are getting care. And you guys, all you doctors know the Hippocratic Oath. I mean, you're going to serve people. And then those costs get passed on to the rest of us. And so anyway, that's why I'm supporting it. I think it's the right thing. And then we know the Oregon study, we're going to save some lives. Out of the 50, 60 people in these groups we know the mortality rate, we're going to save 3-4 people a year. So I think we're going to improve the lives of a lot of people in this state and move them then out of this, because people go into this program when they've lost jobs, when bad stuff has happened, right? And we have that kind of economy where people get hurting a little bit. So anyway, I've taken my time on this. I really appreciate the committee's thoughtfulness and your work on this and your good debate. Really appreciate all of you. Appreciate everybody here. And regardless of what side of this issue you're on, right, we're still all in Wyoming. It's a beautiful place, and we're in the greatest country ever created in the United States. And so we got a lot of blessings. So as we leave here, and most people are good, whether they're in Pennsylvania or New York or California or Wyoming, most people are good. And let's always keep that in mind. So with that, Ms. Jeffrey, can you please call the roll on House Bill 80 as amended?
Yes, sir. Representative Bear,
No.
Representative Byron,
Aye.
Representative Locke,
No.
Representative Northrup,
Aye.
Representative Oakley,
Aye.
Representative Storer. Aye. Representative Strzok,
No.
Representative Zwanitzer,
Aye.
Chairman Harshman.
Aye.
The vote is 6 ayes, 3 noes. The bill passes.
We are available. You want to visit some